Most people don't lose sleep worrying about being injured on the job. Hazards vary widely from one job to another, but one danger most of us don't think about is being attacked by the people we serve, unless you're in healthcare.
I don't think I know a colleague who has not had some physical encounter with a patient over the course of their career.
Lisa Wolfe is director of the Institute for Emergency Nursing Research at the Emergency Nurses Association.
In the study that we've done, that the Emergency Nurses Association did, what we found was 56.7% of nurses reported having either been physically assaulted or both physically and verbally assaulted in the previous 7 days.
In 2014, there was a survey of emergency medicine nurses that reported that 80% of EM nurses report being attacked within the past year. And a survey conducted by our Association of Emergency Medicine Physicians noted that 1/4 of emergency medicine physicians report that they've been victims of physical assault in 2012.
Dr. Christopher Mikos, a longtime emergency physician in Connecticut, says studies show the rate of violence perpetrated against healthcare workers is nearly 4 times that of other industries. The Federal Bureau of Labor Statistics says that of the more than 25,000 significant injuries per year reported nationally as a result of workplace assault, nearly 70% of them are in healthcare.
I have been verbally assaulted. I have been pushed, slapped, punched, spit on, had a gun held at me, and have been held hostage.
That's Dr. Ronald Wyatt, a practicing internist for 25 years, who now tracks this issue as medical director of the Division of Healthcare Improvement for the Joint Commission. That's an accreditation agency for hospitals and other healthcare institutions. Wyatt says assaults occur most often in the emergency department, and patients are the biggest source. Wolfe agrees.
Those include patients who are impaired as they come in and patients who come in from violent encounters to start with. So if your patient comes in handcuffs with the police because they assaulted someone, chances are good that they might be violent in your department as well. We see this also in patients who are under the influence of alcohol or drugs. A lot of times they don't want to be in the emergency department. They're very focused on getting out of the emergency department. But we do see also the environment itself can provoke feelings of frustration that result in verbal or physical confrontation. And those are things like really crowded waiting rooms, long waits, situations where there's an unexpected death in the emergency department and family members are angry, they're upset. So that can spill over into a violent encounter as well.
Wyatt says reported violence against healthcare workers is up by about 50% in just the last 3 years. But Wolfe says there are only theories as to why.
Certainly, I think that violence has become somehow more an accepted solution to people's frustration. There is some discussion that the focus on customer service has made patients have fairly unrealistic expectations of what their emergency department care will look like in terms of speed and disposition. So, people are in the emergency department, they're upset that they haven't been seen within 15 minutes, and that's just not always possible. So to kind of provide realistic expectations of the length and the course of care, I think is important. I think that because more and more people come to emergency departments, it gets crowded and the wait times get longer. And certainly if you're there for a sprained ankle and we have somebody coming in cardiac arrest, well, we take the sickest people first, and that gets people upset.
Nurses and doctors can often see violence coming in a patient who's drunk or demented. But occasionally, and much more dangerously, bereaved family members may plot retribution against doctors who they think botched their loved one's care. Wyatt had fears it was happening to him a few years ago when he walked into an exam room for a new patient visit, an older woman accompanied by her husband.
When I walked in, she reached in the shopping bag and pulled out this really large photograph of a former patient of mine. I immediately recognized the patient. How could I not? Because she was a young woman who died quite unexpectedly. And I said to them, I can't talk to you about this patient. At that point, the gentleman moved behind me, and in a soft voice, he said, you're going to talk to us or you're not going to leave this room. So I did not have in that setting, any way to alarm the staff. So what I chose to do was sit and talk to them. And one of the concerns was, well, if this guy has a gun or she has a gun in the bag, then I'm going to put other people at risk if I start to fight with them to get out of that room.
Wyatt eventually showed the couple computer records detailing the efforts he and his staff had made to save their daughter. The couple left, and Wyatt never saw them again. The incident points up the fact that private rooms can be safety hazards. Wolfe says it's most acute in emergency departments.
When I started working in emergency departments, it was a horseshoe with curtains. You could see all of your patients. Nobody was hidden. Now there's this push for privacy, and that's all very good for patient care, but you're stuck behind a door, and your colleagues can't see you, and they can't hear you, and it's a little bit scarier to go into a room with a patient. The thing is with nursing, which is different from other professions, is that we have to get into people's personal space in order to do our jobs. If you're angry and you're under the influence, I still have to take your blood pressure. I still have to get a blood sugar. I still have to touch you. I have to get within reach where I can be hurt.
In fact, seriously hurt. Violent patients have clubbed nurses with steel bars ripped from beds. Punching or kicking are common. So there are plenty of injuries, both physical and psychological.
People have real psychological residue. You get really skittish. They refer to it as an almost PTSD-like phenomenon. They go back to the room where they were physically assaulted and, they sweat. They have panic attacks. People have lasting physical sequelae, torn rotator cuffs, concussions, broken arms. Again, not nearly as common as more, I'm going to put air quotes here, minor injuries like being bitten or being slapped. But in what other occupation where you're helping people are you expected to take abuse from those people? Also, I think what's important to note, a third of emergency nurses considered leaving their department or nursing altogether because of violence.
So what can nurses and doctors do short of walking out the door? What should hospitals be doing? Many of them post guards in the emergency department. Electronic medical records may flag patients as having been violent on previous visits. And healthcare workers like Mykos need to keep their safety front of mind.
I think about it. I'm concerned about it. It's modified my behavior in terms of making sure that I look around if I'm dealing or confronting a potentially hostile situation or a hostile patient. I make sure that I have adequate resources available to me. We're increasing our use of sedatives for violent patients these days, and we're also increasing our use of restraints. But if I sense at any moment that this is going to become a violent situation or put myself or the staff at risk, I'll call the appropriate code alert to bring security and resources to the department to either restrain the patient or just have a show of force to protect myself and staff members and the patient.
But Mykos and Wolfe agree that's not enough.
People talk a lot about, having appropriate security, and that is so far down the road that it seems worth it to me to really invest some effort into the initial recognition and mitigation of escalating patients and families than it does to worry about whether my security guard has a gun in my crowded emergency department.
Recognizing threats takes education. A handful of states mandate training, but Wolfe says a surprising number of hospitals don't offer any.
81% of nurses report having taken a course on handling workplace violence. Only about half of hospitals provide the training. So hospital security and managing patients becomes a very reactive process. In other words, this is not part of the basic training for nurses. I taught in various nursing programs in both New York and Massachusetts for 10 or 11 years, and this was never part of the curriculum. And I think it's really important for especially younger or newer nurses to understand when things are starting to escalate, and I don't think people get adequate training on that.
But if violence is such a serious issue, why isn't training routine? Apparently, some hospitals don't think the issue is all that serious. Some don't even think it happens at their institutions. Mandatory reporting of every incident opens eyes to how often it goes on and often forces preventive action. That's why Wyatt says reporting is a powerful risk reduction technique. But where it's not mandatory, nurses often don't report violent incidents. Wolfe says that's typically because when they do report something, nothing changes, so why bother? Surveys by the Emergency Nurses Association show that nurses believe that hospital administrators don't care.
They continually brought security issues to the attention of their administration, and it went unheard. And the sort of recurring question that came up in these was, who has to die? What nurse has to get killed in order for administrations to take this seriously? I think that nurses feel like they need that kind of administrative support that they're not getting. They report security cameras that haven't worked in 2 years. They report panic buttons and nobody comes. When your security team is like one guy for your whole hospital, there's not a lot that you can count on if something starts to get dangerous.
But if that's true, why don't hospital executives do more? Here's what nurses believe administrators think.
Part of it that came out in this qualitative study was that it is assumed that this is part of the job. There is this underlying assumption that the emergency department is a violent place, and if you work there and you get hurt, you shouldn't have expected anything different. This is what people report happened to them when they asked their hospital security to help them file charges against violent patients, police, judges. They've had people say to them, well, you work in an emergency department. What do you expect? And so I think that is the biggest barrier, that there is this cultural assumption that it's part of the job and that we should just accept that as a risk.
So if hospitals really want to prevent assaults on their employees, Wyatt says it starts at the top.
Leadership is at the table. They're not saying go have a meeting on this every quarter and let me know what you decided. Leadership has to be at the table, actively engaged in the entire process if you want to build what we call a robust workplace violence prevention program. So there are multiple facets of it, and it has to be continuous. It can't be a one-off, one-time-a-year training, one-time-a-year simulation. We train you when you hired, and then a year later. So it has to be a more proactive approach, because after all, we're talking about prevention.
If nothing else, hospitals should get serious about violence against their workers because of the economics. If nurses quit due to violence, that's a huge amount of skill and experience walking out the door. And according to the government's Occupational Safety and Health Administration, about a third of employees' sick leave due to injury results from a patient's attack. You can find out more about all of our guests on our website, radiohealthjournal.net. I'm Reed Pence.
Medicare and their list of suppliers continue to change, so if you have diabetes, it may affect where you get your testing supplies. But rest assured that your #1 doctor-recommended one-touch testing supplies are always covered by Medicare Part B at your local pharmacy and approved mail-order suppliers. Dr. Brian Levy, Chief Medical Officer at LifeScan, maker of one-touch products.
Some mail-order suppliers may offer a limited selection of diabetes testing supplies. They may try to switch you to a different brand, saying your current products are no longer covered. That's just not true. You are entitled to continue using the products you know and trust and that have been recommended by your healthcare professional at no additional cost.
Remember, you have a choice. Stay with the #1 brand used by Medicare patients. For questions about coverage or where to get your one-touch testing supplies, call 1-866-621-6216 or visit www.onetouch.com/Medicare. Medicare Part B is not a guarantee of coverage and payment, which may be subject to coinsurance, deductible, and patient eligibility requirements.
Is your daily routine putting you at risk for catching the cold or flu? Each year, there are 1 billion cases of the common cold or flu in the U.S., which typically begins when virus droplets are inhaled from a sneeze or cough or transmitted by touch. Placing yourself within close proximity to infected people or surfaces may put you at a higher risk. Curad Chief Nursing Officer and Advisor to the American Nurses Foundation, Marty Moore, has a few suggestions for staying protected.
We all know it's impossible to never leave your home or wear an outbreak contamination suit to ward off germs. But you can assess your risks and take simple steps to help protect yourself, such as using hand sanitizer, wearing a Curad antiviral face mask when out in public, and avoiding excessive workouts.
Whether you're a working mom, stay-at-home dad, or college student, Marty advises all people to take a cold and flu assessment quiz and receive a personalized protection plan at Curad.com.
Health and fitness goals are often at the top of everyone's resolutions list. Older Americans share in those too, and Silver Sneakers Fitness can help. Silver Sneakers is the nation's leading fitness program designed for older Americans. They can help you set goals and find motivation, whether it's playing with grandchildren, completing a race, or traveling for a dream vacation. Sims Corbett is Senior Learning Designer for Silver Sneakers.
One of the biggest predictors of success is planning to make fitness and health changes in a manageable and reasonable way, setting small goals and doing what you love. One of the easiest ways to get started is with our Silver Sneakers classes that are offered in neighborhood settings, from adult living communities and senior centers to park, churches, and more. Members can enjoy classes such as walking, hiking, yoga, and Tai Chi, just to name a few.
Silver Sneakers has changed thousands of lives, and more than 12 million people are eligible for the Silver Sneakers fitness benefit through leading Medicare Advantage health plans, Medicare supplement carriers, and group retiree plans. Find out more at silversneakers.com. That's silversneakers.com.